Just a brief introduction. I think probably everybody on this call knows Michele very well for her work in spinal cord injury and rehabilitation and motor learning and exercise interventions. So Michele is a professor and associate director of the School of Health and Rehabilitation Sciences. She started her career in physical therapy back at the University of Utah, followed up with a master's and education doctorate from Teachers College at Columbia University. From there, she then did a postdoc at the Medical College of Pennsylvania for a year, and then followed that up with a postdoc here at OSU with Jacqueline Bresnahan and Michael Beatty for 2 years. Then she worked her way through the research science track all the way to full professor and became a full professor here in 2008. What impresses me about Michele is that she does both preclinical and clinical research with her interest in spinal cord injury and motor recovery. She takes advantage of all her expertise in behavior and physical therapy, looking at recovery in the context of rodent injury and also in human injury. She's won numerous awards for her teaching and her research here at OSU, including the OSU Distinguished Scholar Award in 2020. She has many papers, over 60 or over 100 total publications. And I think many know of her from the Basso mouse scale, which is one of her most highly cited papers, and really looking at that behavioral outcome, like finding ways to quantitate behavioral outcomes in rats and mice after injury. Her work is published in Experimental Neurology, Journal of Neurotrauma, Journal of Science and Physical Therapy, and many other journals. She's been a well-funded PI both for her clinical and her preclinical work. She's been supported by the NIH, Christopher Reeve Foundation, Greg H. Nielsen Foundation, NIH, and today she'll give us a talk on her work with myelin and recovery after SCI. So Michele, thank you for coming, and looking forward to your lecture.
Thank you for that really generous introduction. I'm just sharing my screen right now and going full. There we go. Everybody can see that? You can see that, John?
Yep.
Okay, great. It's really nice to be able to come and give this lecture today. I wanted to begin by making sure people are aware of my conflicts. Most of my work that I'm going to talk about today is funded by the sources that John has already talked about. And I am currently updating a book chapter with McGraw-Hill, a textbook for physical therapists. And so that is still ongoing. These are the objectives for the talk today, and people that are doing it for CME will get evaluations, so be sure to fill those out. These are the collaborators that have contributed to the projects I'm going to talk about today. We've benefited by having some really skilled experts at the University of British Columbia with Laura Boyd and her team. Also with Jim Schmiedler at here, who is at University of Notre Dame. And then, of course, the experts that we see every day. John Godbout has been a significant contributor to some of the things I'm going to talk about. All the myelin work was done under the close supervision and great help of Dana McTigue and her team. So I'm going to get started. And of course, most of the work was part of Tim's dissertation and Chris Hansen's dissertation. So I'm starting my talk for the first time in my career with a reflection and a thought process that stems from the first time I treated a patient with spinal cord injury, having graduated from the University of Utah, and now I'm a full-fledged practicing member of the physical therapy profession, graduated top of my class, knew everything, consumed everything that the professors were able to give me, never stopped asking questions, and I still ask questions. Most of you guys already know that. So I left understanding what my role was as a physical therapist in helping people with spinal cord injury get on with their lives. And those things were all focused on having people adapt to the condition that they had, teaching them to use other things, sometimes assistive devices, sometimes their arms instead of their legs, sometimes changing their whole environment around them in order to go ahead and live their life, not like they lived it before, but have a high quality life. The crux of this approach is that it takes a compensatory approach. It asks it asks me as the therapist to show them how to adapt, how to change, and how to live with the condition. It also comes in with a fundamental understanding that people with spinal cord injury are not expected to show much recovery, if any, and the best thing to get them back into their lives is to teach them how to adapt to it. The other piece that I knew fundamentally and really relied on is that I was able to see patients in inpatient rehab for 5 or 6 months. And in the rehab department, we would see people every day for an hour and a half an hour on Saturdays. So that meant that we were seeing people at least 5 hours a week over 6 months' time. So we had a lot of time to teach people how to adapt. So so here's my case, my first patient with spinal cord injury, and it was at the University of Utah, and it was a young father. I'm trying to capture it in these images here. It was a young father, a new dad, who was a line worker on for a power company, and he worked in the at the border between Utah and Wyoming, and that is a really high-paying job because it's risky and there's a lot of technical expertise. And he had a freak accident while he was on the pole, and he got hit by lightning. It was a kind of lightning that does happen sometimes in Wyoming, and it was sunny outside, but he got hit by lightning. And unfortunately, it hit him on the top of the head and then ran through his spinal cord and exited through his foot. So he had electrical injuries, he had burn injuries, he slipped down the pole. He didn't fall all the way to the ground, but he did slide down the pole and came to a sharp arrest. And people were having to give him CPR, but they were trained in it, and they life flighted him to the university, and he survived. So his big goal now is to recover, to be able to take care of his brand new son. And his goals are to get home and return to the life he had, not adapt to the life he has now. And this complex case was, it's still, I still remember it. I don't remember most of my cases, but I remember this one because the tools I had to get him where he wanted to go were really non-existent. I had a game plan. The way we were moving forward was to teach him how to live in a wheelchair, how to navigate that wheelchair, how to avoid any life-threatening conditions like decubitus ulcers or contractures or things like that. And at the same time that we're working through these things over these months in therapy, he's starting to have recovery because his injury is so unusual, and the electrocution part of the injury was resolving, and there were no tools in my toolbox. And I left this case understanding that I didn't know enough, that I wasn't a good enough therapist. I wasn't being the therapist I wanted to be. And I went to grad school at Columbia the very next year. So that's how I ended up where I'm at. But this is kind of a nice foundation for how spinal cord injury rehabilitation is changing. And we're recapitulating some of these ideas even now in 2022. So what's happening over time is I've been in the field long enough that I can see that the number of spinal cord cases is increasing year over year. It started around 6,000 when we started having good records of how many happened per year. 6,000 is not many. Now it's almost 18,000. The other thing that is happening at the exact same time, but moving in the wrong direction, is that the lengths of stay and the access to intensive rehabilitation is actually going down. It's actually gone down by 65%. The length of treatment that people are receiving has gone down by 65% from its peak. And so with so little time, and especially in the early rehabilitation phase, in the inpatient rehabilitation, where we could count on some enough time to really assess the person and teach them really good life-sustaining skills, now we're having to prioritize only life-sustaining skills, and everything else is being done in the outpatient setting. So it's not uncommon. It's very common now that that inpatient rehab is focusing on transfers and strength training for the muscles that have been spared to maintain body function, so that they don't leave inpatient with having contractures or decubitus ulcers, or and that they can use their wheelchair to navigate. The length of time that they're in rehabilitation now is, instead of being in for 6 months, the average time is now, the last time we have good numbers is 21 days. So that's only 3 weeks. So we went month over month rehab time to now days to do rehab. And we're focused again on these compensatory approaches, because we have to make sure that the people can survive this injury. But we are not left with much time, or any time in a lot of cases, to do anything that is pro-recovery. We're back where I started, saying, hey, people are going to recover from this. There is an opportunity for plasticity and motor learning to happen, and we need to know how to do that. And more importantly, we need to be really effective at doing that, because we have less time to get that done. So we start in our lab, we're looking at our goal that we set for ourselves is to understand what some of the limits to recovery are, and then how can we get more out of every movement we do. So the thing I always say in the lab is, how do we get more bang for the buck? So we do the one thing, we do one motion, but how do we engage the nervous system to its maximum? Because we only have time to engage that nervous system in a really meaningful way through those actions, and in very limited time. So we set up this three perspectives that we're interested in, and we think that things that limit recovery, or that will tell us how to get more bang for our buck, are going to be centered around task-specific rehabilitation, around questions about the type of training that we do, the timing that we do, and what the dose is like. the other thing, especially in terms of things that might limit recovery, we think we're going to see that in terms of the injury mechanisms and how far that injury spreads throughout the nervous system. And then lastly, I am sure, and the evidence is strong, that there's going to be the opportunity to profoundly impact plasticity if we can do the right thing at the right time, at the right intensity, and avoid anything that's going to limit recovery. So I'm going to start the talk by looking at these independently. And the first thing that I want to share with you is some evidence that we published from some work we did in the NRN, which is a task-specific training program for locomotion in people with spinal cord injury. And these people were the people that we're talking about here had over 120 training sessions that were at least an hour long. And these training sessions were carried out across multiple centers, and their lead rehabilitation centers in the United States. And they specifically focus on, this paper specifically focused on Asia C and D. That means that people had incomplete injuries and some sensory and motor function, excuse me, below the level of the injury. We also were lucky, because this is a multi-center, that we had a relatively large population of patients. 68 people got the same training and the same outcome measures and the same decision making, which is pretty rare. And we also were able to do 6 to 12 month follow-up. And we had a wide breadth of outcome measures that we did, and I'm only going to emphasize a couple here. So the study is based on a design where it's a case-controlled study. So we're comparing the change over time of these people that received 120 sessions. So they serve as their own control, but they also serve as a cohort because there's 68 of them. Across the bottom of these slides are the sessions that we delivered of training. So everything is demarcated, and we did outcome measures after every 20 sessions of training. I'm emphasizing here some of the functional outcome measures, because being able to transition into being more functional is the goal. It's how I started. It's why I went back to school. And it's how we're going to drive the most plasticity we can. So we did 2 walking measures, the 10-meter walk and the 6-minute walk. The modified functional reach, which is a very sensitive tool for people that are spinal cord injury, especially because you can do it in the chair or standing up. And then a balance measure. What we're showing you with these outcome measures is divided into 3 colors. And these colors are statistically determined. They are done off of the real change, and real change means that the amount of improvement that we see is beyond what would be accounted for by random probability or random chance. So that has a clinical meaning, and it's called real change, and we applied that here. So what I'll first start with is the pink, and the pink is designated the first real change that people made, of the 68 people that they made and when they made it. So you can see that depending on whether we're talking about the walking measures or the balance measures or the reach measures, that of the and this you can read as 100% of the participants. So for the modified functional reach, 40% of the people in the cohort made their first real change in reaching after 20 sessions. 25% made first real change in balance, 20% made first real change in 6-minute walk, which is for endurance, and about the same 20% made real change in 10-meter walk, which is a speed measure. How fast can you walk? Now, what I want you to notice first is that across all these really important functional measures, we see first real change happening all the way across. So some individuals are making first real change on walking measures after 100 sessions or after 120 sessions. And it doesn't matter which functional measure we look at. We continue to see real change and first real change in these measures coming way out. We don't see a plateau. This means that we can count on delivering 120 sessions and still have significant improvement in walking. Now, the next thing that's really interesting is the gray, because the gray means that they've done a consecutive real change. So we had 20 people that did real change, 20% of people did the first real change, and then they continue to make consecutive real change, 20 sessions over 20 sessions. And you can see that that also continues and never drops off. And then lastly is a maintenance of real change. So this means that they made real change, either a consecutive real change or first real change, and now they're maintaining it over those 120 sessions. So this longitudinal approach, which is intensive training and well surpasses what standard of care is showing us that there's no plateau. And the really exciting piece is that these real changes were maintained significantly different than their pre-performance out to 6 months and a year. The other thing that's really surprising is, for the first time, we have some evidence that this kind of training that is focused on treadmill training and capacity building has improvement, brings about significant improvement in some bowel and sexual function measures. This is based on a smaller group of those 68, and we have a lot more data that we can drill into this even more. Skip that. So now we have this this idea that people with spinal cord injury will respond to therapy what appears to be indefinitely if we are doing an intensive therapy and it's activity based. Now the question is, now we're really interested in these injury mechanisms and where these kinds of changes could be occurring within the nervous system. So the first thing that we wanted to understand is, what are some of the, how big is the lesion? We know that the epicenter of the lesion does expand and can span 2 or 3 segments of the spinal cord. We know, we jumped then into some animal studies and wanted to know more about what happens, how far that lesion expands, because there doesn't necessarily have to be an overt lesion that we can see on imaging for there to still be a lesion that extends well beyond, or lesion processes that extend well beyond where the primary injury is. So in this experiment, we analyzed, we did a thoracic spinal cord injury and at T9, and we looked 10 segments below the injury in the lumbar cord. And we asked the question whether there was any inflammatory profiles and trafficking and inflammation occurring well below the injury. And we set up the experiment looking at gene expression of inflammatory genes that are shown along the side. You can see the classifications: inflammatory genes, trafficking genes. That means we're trafficking monocytes and neutrophils out of the blood and into the parenchyma of the lumbar spinal cord. We're looking to see if that happens, and also looking to see if extracellular matrix remodeling is occurring and is an upstream regulator of some of this inflammatory process. So, oh shoot, let me back up real quick. You can see that the control gene expression for some of the genes of interest in these three families are very low. Anything that's white or blue is low expression, low homeostatic levels. And you can see that at 1 day after a mid-thoracic injury, we see an early and immediate increase in shown in red, high levels of gene expression related to remodeling, trafficking, and inflammation. And those elevated levels continue at 7 days, and even at 14 days, they're still resolving. By between 14 and 21 days, we can see that these inflammatory processes and trafficking of peripheral myeloid cells is starting to resolve. So this tells us that there are periods when the inflammatory signaling is very high, significantly high, but that they wane over time, and subacute periods may offer a alternative place or source or time for us to be able to deliver our therapies. Now remember that this is 10 segments away from the primary injury site. This is we were one of the first labs to be able to show this very expansive and remarkable response. We also did a study with John Godbout's lab where we used bone marrow chimeras, and the bone marrow cells were replaced by GFP positive cells. So these cells will be green. And when they go into the circulation, or when they move into the parenchyma or into the lesion center, we can see that because we can look for this green autofluorescence. So in these chimeras, after we made these chimeras, we gave them a thoracic spinal cord injury. And once again, we looked in the lumbar cord, 10 segments below the injury. And what we see is that there's a profound increase in infiltration of these myeloid cells within the dorsal part of the spinal cord, the intermediate part of the cord, and in the ventral part of the cord. Everything green here means that it is a myeloid cell or a neutrophil. And I'll call your attention to that we see these as early as 24 hours after spinal cord injury. And they are and they represent a significant inflammatory process in the lumbar cord. So it's not just resident glial cells that are encaptured in this process, but it's also cells that are coming in from the bone marrow caused by the spinal cord injury itself. The next thing that we wanted to understand is what is the best time if we have this really early response and it's extending well below the injury, well away from the injury site in areas that we thought would be largely protected. What is the timing and the effect of this inflammation if we do early training? So we did an experiment where we did early training or late training. The training was exactly the same, and it's a treadmill-based training program like that we use in the in human spinal cord injury, but this is in mice. And what we see is if we do early training when inflammation is very high, especially in the lumbar cord, we see a significant increase in the number of toe drags that occur in our trained animals. And it's significantly more than the animals that got no training at all. They still have inflammation in the lumbar cord, but they weren't trained. So this is a significant difference. And it means that this doing training in this early period of frank inflammation, it could actually worsen the functional profile of it does worsen it in animals with spinal cord injury, and it could pose a potential and serious risk to people with spinal cord injury. So we have to be careful, and maybe one of the strategies is to either control the inflammation pharmacologically or avoid it by going later. So now we know that the efficacy of rehab is not only determined by the type of training that we do, but also the timing of the training and what the inflammatory microenvironment is like. It is critical and will be a barrier, at least early after injury. The thing that we don't understand and hadn't looked at is whether the lesion also expands rostrally, and those same inflammatory processes that happen well below the injury could be happening in the cervical cord. So we did the mid-thoracic injury and we looked above the cord, and again we're using the GFP chimera mice. So anything green here again is myeloid cells coming in from the blood, so neutrophils and monocytes. And what you'll see, this is at 14 days after spinal cord injury, and what you'll see is that there are no GFP positive green cells above the injury. The cervical cord appears to be a protected site, but below the injury, there remains these cells from the blood, and they're there at least at 14 days, and they may be resolving, but they show they're significantly increased throughout the cord in the lumbar cord, but not in the cervical cord. So this gives us a place where we might be able to drive plasticity, a protected zone where we could drive plasticity and then bridge axons to the lumbar enlargement. Or we could wait a little longer when we're thinking between 14 and 21 days, at least in mice, where we could deliver our therapy. So the key takeaways here is that the inflammatory microenvironment will be a barrier to recovery. It can actually make things worse if we do it on top of treatment, and that we have but we do have some windows of opportunity. There may be a window that opens up later, so more chronic or later time points, subacute time points might work, or targeting the cervical cord might help. So now we are realizing that these independent studies of rehabilitation and injury really need to be considered in a multifactorial approach where all three of these things are affecting each other and affecting the outcomes and are pivotal to hitting this tiny little space we need to target in getting greater recovery. So now we're using this multifactorial approach, and the challenge we set for ourselves is to really get more bang for our buck. We have to be innovative in how we think of the problem, and we have to require the rehab paradigms we want to test. We have to have a strong rationale that they will activate the CNS more effectively and than the standard treatment would. So we come in saying we have to do more. We need more. For every movement, we need to gain more than what we know we can do now. So we came up with a hypothesis, and we designed and tested an eccentric motor training program for spinal cord injury, because there's strong evidence that it engages the nervous system, the CNS and the spinal cord differently and more effectively than just a regular strength training program or a regular locomotor training program that doesn't emphasize eccentrics. So what's the evidence that I'm speaking to you about? Well, there's really nice evidence in using EEG in the brain, where they've compared concentric strength training paradigms to eccentric training paradigms. And you can see that the engagement of the brain and the motor planning regions of the brain are greater and expand more after eccentric training than with concentric training. And we can be very specific using EEG to what areas are responding in a greater capacity. Here, red is concentric and blue is eccentric. And so we have these motor planning regions, and also the primary motor cortex itself is showing really good responsiveness to eccentric training. So based on these things, we know that the CNS is greatly engaged by eccentric training, and there are also some skill-based benefits of this. One of the things that we know is that there's a primary, when we walk, there is a part of locomotion that is almost entirely eccentric. And that is the part of locomotion where your limb is placed on the ground, and then the weight of the body is displaced across the leg. And when that happens, there's eccentric work to lower the foot down to the ground, and eccentric work around the quads and the hamstrings that allow weight acceptance and the knee to act as a shock absorber. So to try and dissipate the ground reaction force that happens when the leg strikes the ground. This phase is called a weight acceptance phase. And some of the key muscle groups are shown here: the quads, rectus femoris and vastus lateralis, and the hamstrings, and we're specifically looking at the semitendinosus. Then, of course, the foot drop, the foot lowering is done by the tibialis anterior. So if we look at this very specific phase of gait, we get a really nice look at what the motor control of eccentric work can be in a functionally meaningful task. The other thing we know is that we can drive even better eccentric control by having the treadmill slope downhill. Downhill training has been known for a long time to be an excellent way to train for marathons and ultra marathons. And we have so we thought we would look at to see if we have greater activation in downhill in animals that have spinal cord injury. So this is work that was done by Raquel Menarche. Some of you know Raquel. She's a technician in the lab and a physical therapist, and she did some of this work as a PT student. What we're able to do is use EMG as a measure of activation of the nervous system, especially of the spinal cord, because the motor neurons in the spinal cord are what are causing these EMG signals in the muscle. Here we're looking at the semitendinosus, and we looked at this in the same animal. These were rats when they were walking on a flat treadmill, and then immediately within 5 minutes after lowering the treadmill so it was on a downhill. So we're looking at the same animal with very little time elapsed, and they do have spinal cord injury. And what you can see is the flat treadmill is shown in gray, and the downslope treadmill is shown by this purple trace. And if we fill in the area below the curve for the flat, you can see the profile of the EMG signal for the semitendinosis. Now, when we slope that treadmill downhill, you can see there's a significant increase in the EMG activation of the semitendinosis simply by moving the treadmill downhill, changing the slope. We asked the same question in people with spinal cord injury, and again, gray is the flat treadmill condition. Green is that it's on a slight slope, which is a 10% grade. And then pink is that it's on more of a slope, and that's 20% grade. And what you should be able to see is that there is an increase in the overall activation of the spinal cord of the based on EMG at both the 10% and the 20% grade. And the steeper the slope, the greater the engagement of the spinal cord. So now we know that we could do downhill training in both animals and humans and have more bang for our buck. One of the things that made us really excited about thinking about downhill training is that there was some work done by Mackenzie, and he was looking at mice, normal mice, that had to learn a complex wheel running task with a real unpredictable rung pattern. And the animals were trained to run on this, and then they looked at the amount of motor learning that would occur if the animals had a gene knocked out that prevented any myelin plasticity from happening. So it prevented myelin formation and new oligodendrocytes from forming. And then they compared it to animals where that was where myelin formation was free to happen. And the red line is showing animals that had suppressed myelin formation, and the blue line are animals that had pronounced new numbers of new oligos and myelin formation after this wheel running task. So we now know that this part of the ability to see skill learning, motor learning, get recovery for people with spinal cord injury may hinge on the ability to drive a task to drive motor learning and plasticity of the white matter. So that's our question now. We're doing this multi-dimensional experiment in mice and looking at oligodendrocyte, the development of mature oligodendrocytes and their ability, if they do mature, their ability to myelinate axons after spinal cord injury. And we're specifically, we are trying to optimize this experiment by doing the training late in that later phase where we know that there's some resolution of the inflammatory processes in the lumbar cord. We're targeting downhill training because we know it targets the central nervous system and the integration of afferent information and descending motor control commands. And we're using some really nice tricks to look at oligodendrocytes that Dana McTigue developed and her lab developed, and she oversaw these parts of the experiment. So we used PDGF receptor alpha mice, and they they had a Cree reporter for TD tomato that was turned on. Those genes were sorry, turned on using tamoxifen. So we delivered tamoxifen after in the chronic phase of injury, so at 29 days and to 32 days, then we let the animals acclimate to that new their new state, and also to have some of these oligodendrocytes be maturing or being primed to mature due to downhill training. So we did this training, and then we did kinematics and did histology. And again, we're going to be looking for these oligodendrocyte precursor cells. And we know that we'll know that they're mature cells because we stain with CC1, which is a marker for mature oligodendrocytes. So we're looking for double labeled cells that are green and red. And then we'll look at them to see if they're around myelin, around neurofilaments. So here's the exciting news. We had two groups, one group that had downhill training and one group that was unexercised. And you can see that there are GFP positive oligodendrocyte precursors in both groups. But in the downhill group, these oligodendrocytes are mature oligodendrocytes, and these yellow arrows, anytime you see yellow arrows, they're pointing to yellow areas that indicate there's overlap, that it's double labeling of the oligodendrocyte and the CC1. So these are mature oligodendrocytes that occurred due to downhill training. And this is an OPC that is not a mature OPC because it's not double labeled with red. And when we quantify the number of mature oligodendrocytes, you can see that there are significantly more mature oligodendrocytes in the dorsal columns of the downhill train group, and there's no real difference or improvement in mature oligos in the untrained group. Now, the next question is, what do we know about their ability to myelinate? So just because they're mature doesn't mean that they're actually wrapping axons. So next, our red marker labeling here is for neurofilament. So that's going to label neurofilament that's within the axon itself. And the yellow arrows are showing, this is the naive condition, and the yellow arrows are showing that there are routine areas of oligos wrapping axons, but they're very few. And these are probably occurring over time at a very low rate. However, in the downhill group that we downhill trained, you can see that these arrows are pointing, there are more arrows pointing to myelin wrapped axons. And there's significantly more of these than animals that had no training at all. So the injury itself does increase slightly the number of labeled myelinated axons, but downhill training is responsible for really driving the myelin plasticity that we're seeing here. And here's a 3D stack from a confocal image. And I know it's probably hard to see, but this is looking at a longitudinal image plane, and right in here where my marker is the area of showing that this is an axon that is wrapped by a mature new oligo in the in the downhill trained group. So what do we get by doing downhill training from a functional standpoint? Well, we see kinematic differences that are that allow the height of the limb and the hip height to be closer to normal. Normal here is shown in the dotted line. Unexercised group is gray, and the downhill group, downhill trained spinal cord injured group, is in red. And you can see that downhill training is significantly improves and brings the behavior closer to normal, and greater impairments exist in the untrained group. And it doesn't matter which phase of gait we look at. It happens in in the initial part, when the limb touches the ground, at liftoff, and in the during the swing phase. What's really exciting to us is that there's some evidence that there's a strong, significant relationship between the number of new oligos and the improved hip position, so that the more new oligos we have, the closer the hip position is to normal. And that's shown here. So this was a significant correlation. And this, during the flexion phase or the swing phase, we had a trend. So this p-value was p equals 0.09. The other nice thing that we saw is that we didn't instigate, downhill training didn't create an inflammatory condition. TNF alpha and IL-1 beta are significantly elevated during flat treadmill training. But in downhill treadmill training, they're actually reduced relative to the flat expression. So we're creating and eliminating an inflammatory microenvironment by doing downhill in the lumbar enlargement. So we're showing now that complex eccentric training is a potent inducer of white matter plasticity, and it does drive axon myelination or remyelination. It is associated with motor learning and improved motor control. And we may have successfully avoided that inflammatory period and found a sweet spot where downhill training can be an effective driver of recovery. The next question that we had is, what happens in human spinal cord injury? Can we create a pro-recovery period in human spinal cord injury? I'm going to go through this part really fast. We measure this human injury using a technique that was developed, and really there's a lot of excellent research done on it at the University of British Columbia, where Laura Boyd is, and it was done by McKay and his group. And what the MRI technique does is it captures these spikes of water, and the medium spike is this spike. This larger spike here is capturing intercellular water and interparenchymal water. This tiny spike is capturing the water molecules that are trapped between the layers of myelin. So if they have developed a technique where you can measure this tiny spike and put it in a heat map, and which aligns with areas of high white matter shown by lighter colors moving into red and yellow. We know Laura has produced some really nice work showing that exercise-dependent myelin, increased myelin water fraction occurs in the brain and is specific to the limb that is trained, and is not just an overall general effect. So it is specific to the hemisphere that's doing the work. And we designed a study to look at people that have exhausted all their rehabilitation efforts. They've completed NRN training. They're out at least 10 months after any organized physical therapy, and we bring them in and we do downhill training with them. We use a harness system when we need to. We compare them to, uninjured controls. The interesting thing is that the time since injury in these individuals is from 6 years to 48 years after injury. And remember that the longitudinal data suggests that these individuals may continue to make real gains even this far out, although no one has really ever shown that. And we had 3 individuals that we were able to capture this data on. We actually did it in 4, but the MRI data had movement artifact for 1, and we couldn't do it. So what I'd like to do is show you these 3. You will see the pre-image on the left and the post image on the right. And I hope you can see that the expansion of myelin and the myelin water measure is occurring in the post image. We can measure that, and we can see that there are significant increases in myelin formation in areas that are critical for motor learning and motor control. And there are relatively few or no spurious labeling in areas that we wouldn't predict to be activated by the training that we're doing. We see that across all 3 individuals. The last individual had more of a hemisection type of injury, and this is showing you the overall effects of both sides added together. If I was able to show you just the more affected side, you would see that the more affected side did respond to the training. But when you average it across, it doesn't show significant differences. So here's where we're at now. We're circling back to where we have these downhill, where we're able to show for the first time that the motor learning that we're targeting, and the more bang for the buck that we're looking for, is going to be as much white matter focused as neuronal focused. That the type of training we do has to be complex training that engages the nervous system in really hard tasks. And the question now is that the environment for rehab is taking us to a compensatory focused intervention during the prime time when this activation could occur. And so how do we train rehab clinicians to be innovative and find treatments that will get more bang for their buck? Thank you.
Awesome, Michele. Great talk. Really interesting work, and you're looking into the preclinical to clinical is just really fantastic. Appreciate all that work that you do and making those connections. So we will open it up for questions. Generally, if you want to ask a question live, I think we can do that, and or you could post questions in the chat. And so we have questions for Michele. Yes, Andrea.
Hi, Michele. Can you hear me?
Yeah, I can.
Yeah, so great talk, and I really enjoyed. So I was wondering whether you can comment a little bit about whether, let's say, try to gain as much as possible within a short time window. It's really the best way to move forward, or whether you will envision, let's say, try to put a little bit more pressure and expand a little bit more this window where eventually we can really gain even more than what you already described.
Yeah, I think we have some really nice data that we published. I didn't really put much of it in today. I didn't put the main pieces of it in, but we had seen really profound learning effects, training effects with flat treadmill training, even if we could mitigate that inflammatory process early after spinal cord injury. So we were able to see mice be able to walk on a treadmill, well, none of the other control groups could do it. So if there's no inflammation and we deliver the training, we see a really strong interaction that benefits recovery. So one of the things that I think we are heading toward are pharmacological ways, and they could be simple things, but pharmacological ways to control that inflammation, or at least identify when it's no longer a problem. And then drive this. I would like to see us do 120 sessions as early as we can, as early as there's no inflammation, and do 120 sessions. We save a lot of money. I didn't talk about that slide, but part of that 120 session paper talked about the amount of money that we save by instituting these gains and preventing rehospitalizations. So it can be as much as $80,000 to $1 million in these people just by regaining the ability to stand or walk. So that's kind of where that's the one side that I think we could open that window up early. But I also think that if we do a really complex training task, that it avoids that and we have to start later, it will also be effective. The grant that we have DoD right now is looking at exactly that. We're going to take people and we're going to look at their CSF as a marker of inflammation, and we'll either determine a go as early as possible or a no-go and wait until they're 6 months after injury instead of 3 months after injury. And we're doing downhill, and we're also adding, to get even more bang for our buck, we're also adding electrical stim.
That's cool.
So you're thinking the way I'm thinking. And so, and we're actually doing that work all in human.
Fantastic. Yeah. Thank you.
So there's some questions, I think, in the chat. I think I'll do my best to read them. There's a question from Grace Urbar. This was fascinating. What was the MPH set at for the treadmill training during downhill training?
For the mouse or for the human? For the human, it is so normally in NRN training, the treadmill rate is, the main part of training is done at around 2 miles an hour, which is a normal walking speed for people. Somewhere close to normal walking speed. For the downhill training, we slowed it way down. We tried to go as slow as possible because that demands more motor control. It also demands more effort from the brain and the afferent input for integration of the descending signals, whatever getting through, and the afferent information coming in, proprioceptive information coming in. So ours was really slow. 0.2 to 0.6, but I am forgetting if that's in meters. Can Raquel type it in the chat? I can't remember for human, and Leslie will know what it is for animals. I'm sorry about that. It's in the paper. That paper was published in September, and I think it's in there. Okay.
Jan Schwab asks, can you comment on above lesion atrophy happening in human, but here you show no inflammatory changes in animals?
I know, it's really interesting.
Oh, here he is. Maybe he can ask you specifically himself. Here, Jan, you want to go?
Yeah, I guess this was very nicely read. But it really is indicating, obviously, there are changes in human spinal cord above the lesion, and so far these changes go really without any good explanation. And so these changes affect both gray and white matter, and obviously this is a different beast above here, the lesion versus below. So I would not anticipate or would not think it's awkward to have differences there. But on the other side, we have still manifest pathology above the lesion. And so if there's atrophy occurring, I would still assume that there's some microglia activation and so on, maybe in those nerve, routes or nerve tracts which have been have undergone Valerian degeneration, basically the sensory tracts above the lesion, or other even, again, even the gray matter is affected here properly. So
Yeah.
could you just help me
I can comment on that for sure. We see it as a paradox. So in the animals, we have a paper that it's waiting for my final touches on it, but I'll share with you that we have done we have all kinds of markers: CCL2, TNF alpha, IL-1 beta, trafficking genes, gliosis, looking at gliosis. Tim's study is looking at myelin plasticity above the lesion. And all of those show the same thing. They are not elevated in the mouse above the level of the injury, but they are significantly elevated for periods of time in the lumbar cord. Now, the human data has also shown, I'm not going to pronounce this right, but there's a group that's, and I'm sure you know them, Jan, you might even be on one of their papers. It's Feund, Feund,
Yeah.
and they have shown atrophy in the cervical enlargement of humans. And I asked Laura Boyd if the way we collected our data could generate that kind of data for us to look at and see what the atrophy might be like in the cervical cord from this study. But it doesn't seem like we can do that, at least not easily. So we do know that there's atrophy there, but in the mouse, even at long time points, we're not seeing inflammatory processes. So I don't know. This is the paradox. This is really interesting to us. I think that it has to do with preservation of breathing and the neurons that are important for, life. So the diaphragm and things like that. And I think there are special cases. We are really exploring now some ideas about blood-brain. There are differences in the blood-brain barrier. There's no leakiness in the cervical cord. There is in the lumbar cord. There's differences in fibrinogen. There's differences in pericytes. So we're really interested in understanding more about how to make use of that cervical protected zone.
Thanks. I have a brief question, if I may.
Yeah.
So thanks for this nice talk and really a great journey. The second question would be related to your observation that this acute training, can actually result in deleterious outcomes, so to speak. And so this has been seen even also in primates. You may remember also this kind of studies by Martin Schwab at the time, where they tried to, apply these novo antibodies and then try to do the early training. And what they could see is that the early training in combination with kind of removing plasticity barriers was actually resulting in worse learning, worse recovery. Yeah. So this is very much what you also here described. I guess what is really new, however, that this may be attributed to the inflammation. How can you really make sure that this is due to inflammation?
So and I wasn't able to show that, but we've published that work in the Journal of Neuroscience. And the reason that we're saying that is our markers for inflammation were TNF alpha, IL-1 beta, also astrocytes and microglial activation. And MMP9 is an upstream regulator of these inflammatory cascades, and especially of TNF alpha. And we did MMP9 knockout, and then we saw no glial activation, no astrocyte activation, so no gliosis, and no elevated levels of TNF or IL-1. IL-1 beta. So that's how we're saying that. Those are the markers we looked at, and those were associated with animals that could walk, that could respond to training and could walk. If the animals had MMP9 knockout, they still didn't have any of those cellular markers, but if they didn't get training, they didn't walk. And if the animals had the inflammation, they didn't walk. So it's a combination of damping down that inflammatory signal and adding the training. If we added the training late, even in MMP9 knockouts, there was no improvement in recovery.
Thank you.
Okay. We have a question from Laura Boyd. Says, great talk, Michele. Thanks. Can you talk a bit about the challenges of imaging myelin after SDI in humans?
Yeah. So we had a lot more people in this study, and it's really hard to image myelin in the spinal cord because of the spine stabilization hardware that most people have. That can make it difficult. It can kind of warp the MRI signal a little bit. So we have to be careful about that. We have to be careful about how long we leave people in the magnet because they do have spinal cord injury. They don't have great sensation typically. We don't want to put them in a position where they're going to have skin decubitus, and they have to remain perfectly still. The other challenge is that there isn't, because of these challenges, there haven't been a lot of studies that are using these special approaches like this this gradient scale echo series in the spinal cord, because people don't know how it, especially in the United States, because people don't know how they're going to interact with the spine hardware. Now in Canada, Laura has been able to do some of that work, and that's why we're really happy to have her as part of the team. They also don't have the software to as well mapped to convert those myelin water images into heat maps in the cord itself, as they're really well done and been used in the brain for a long time, but the maps for the cord itself are still in progress. Did I miss anything else that
For questions?
Or from Laura?
Oh, okay. Yeah. Oh,
perfect. Yeah, that's why we didn't have very many, but we're really proud of it. I mean, this is the first paper that I've ever done where I had both animal and human work. And, you know, I've been a scientist for 30 years. So it took me 30 years to get here.
Yeah, well, I guess what's that saying? Like that makes it worth it, right? I mean,
it does make it worth it, but usually they say it only takes you about 15 to 17 years to get into human. And so I think I'm still slow.
So we have a few more open questions or comments. We have a comment from Eric Kirby, who says, in the strength and conditioning world, eccentrics are superior for strength benefits. So to be able to see that carry over to cellular myelin changes when eccentrics are incorporated in rehab is very interesting. So I think it's more of a comment saying that's interesting.
Yeah,
connection.
There's a really cool paper that we are hoping that we can really build on, especially in spinal cord injury. There's a cool paper that has shown that if you do eccentric work with the quads on the right leg, and then you measure the concentric force on the left leg, it primes the left leg to deliver more force. If you do concentric force on the right leg and then measure concentric force on the left leg, it's significantly lower than had you done eccentric work. So we know that there's a priming effect within the cord itself in normal individuals and athletes. We think that's also happening in humans. And we also know that eccentrics will help with coordination and it'll protect joints. And that fact that what we really hope we can do is get people to use the knee as a shock absorber instead of a strut and vaulting over a stiff knee. If we can get that, I think we get more complex motor learning skills, and we build on that in a really high capacity way. We did see people move by doing this training, even after they'd plateaued in their recovery. We did see people change assistive devices, go to less restrictive assistive devices, change gait speed, change in spasticity. So.
Okay, Michelle, we got two more and then we'll close it up. We have a question from Austin Hurst. Really interesting talk. I'm curious whether you think motor imagery training might be an effective supplement to regular rehab that could allow for some motor learning before the inflammation has cleared.
Yeah, I think that is a really, it costs nothing. And literally, I mean, it doesn't take away from treatment time. It can be done. It can be done when the person is relaxing at the end of the day. It can be a very formal program, and it can increase in complexity by doing dual task thinking and things like that. I think it's a really good idea. The other thing that goes along with that for me is sleep. I think we have to have, there's really sound evidence now that if we don't have good sleep, we're not clearing some of the toxins and inflammatory profiles that are in the interparenchymal areas of the brain. They're not clearing at night. Usually they clear with REM sleep at night. And there's been some really elegant animal studies that have shown that plasticity is dependent on that level of sleep. And if you disrupt that sleep, you don't get that plasticity. So I think those are two things that we have to do a much better job of as soon as possible in the inpatient rehab setting, in establishing good sleep.
Okay, our final question, Jen, is from Jen Basso. Thanks so much for your presentation. Could you please discuss timeline / chronicity for SCI human participants in high intensity training, 120 session, N equals 68, and frequency / intensity / duration / type info? It's the question.
Okay, so yeah, I think the question is, what did those 120 sessions look like? I think is the question. So they were treated on average, that group of people were seen 4 times a week. They had an hour of active time on the treadmill. Most of that time, 20 minutes of that time, was done with a high treadmill speed and active assistance by trainers to get a kinematic walking pattern that looked kinematically as close to normal as possible. So they added as much help as they needed to get kinematic normalcy. And then the other times were done with some standing training on the treadmill, and also given the person the opportunity to hold and control, take control of those kinematic, the kinematics of walking. Now, in those kinematics where the person was doing it, the treadmill speed had to be slower, but the trainers were going as hands-off as possible. And so it was adapted, it was personalized to every single person. And every session, as they progressed, the things that our hands were coming off of changed. So that gives you a little bit of that. They had, so let's see, what else can I tell you? It was intensive. It had, the trainers were trained, but they weren't necessarily physical therapists. One person on the team was a physical therapist, but all the trainers were interchangeable. And the decisions were to try and get the best kinematics and get that locked in and remind the nervous system what that feels like, what that looks like, and then have the person try and replicate it.
She responds perfect. She says, did you say 3 months out from injury?
Oh, that is for our DoD grant. These people, some of them started within just a few days of injury. If they had a mild injury, all of them had been discharged from inpatient rehab. So, and some of them were discharged at 21 days, and then they started with us, and others might have started much later. And we purposely enrolled people that were at different lengths after injury, so we could look at the efficacy of this kind of training later. We also have different age groups. So some of the people one of the people at our place who I just really enjoyed was 85 and was able to go back home living alone and mowing their own lawn. Wow. So that was cool.
All right, Michele, we'll wrap it up here. Thanks everybody, internally, externally. Sorry, I have to ask. The acute phase, did they have decreased response? From Jen again.
Decreased response to our training. No, I don't think, well, I don't know. I mean, some of the data would be in those first 20 sessions of those graphs I showed you. And so some of the people did respond there and did show their first response at 20% of people showed their first real response in the first 20 sessions. But I don't know necessarily if those first 20 sessions are early after injury or later after injury. We have to look at that. We do have, that database has 600 people in it now. And so we are asking those kind of questions of that database, but it's complicated work. So I don't know the answer. It's a great question.
Yeah. Okay. Well, with that, we will end. Thanks so much, Michele. Great talk, fascinating data as always. Appreciate everybody internally, externally who joined us today, and encourage you to follow up with Michele if you have more insight or interest. And everybody, have a wonderful weekend. Take care.
Thank you so much for having me, everybody.
Thanks again, Michele. Take care.
Thanks.